episode 54 of the Real World Paleo Podcast. Hi everyone, I'm Christine Lehman, a nutritional therapy practitioner and reverse diabetes coach, which is also the name of my website. I help clients reverse diabetes naturally, lose weight, and lower their cholesterol. I also see clients by Skype. We're celebrating the 1-year anniversary of the Real World Paleo Podcast this week. We're now available on iHeartRadio as well as iTunes, Stitcher, and Google Play. If you think the podcast has value with my weekly expert conversations, like the one we're having this morning, you can make a donation on my podcast or blog page at reversediabetescoach.com. Please remember while you're listening to the show, advice and information we provide is intended to be helpful and informative, but is not a substitute for medical advice or treatment. I am really excited to have Dr. Fiona McCulloch on the podcast today. Dr. McCulloch is the founder and owner of White Lotus Integrative Medicine, which has worked with thousands of people seeking better health over the past 16 years of her practice. Dr. Fiona is committed to health education, sharing the most current information on health topics, nutrition, and natural medicine. Fiona has published many articles and is a regular contributor to NDNR, one of the leading journals for naturopathic doctors, as well as other publications for health professionals. Her popular research-based blog has 30,000 readers monthly, and her first book, which we'll be talking about today, 8 Steps to Reverse Your PCOS, will be published on September 20th this year for PCOS Awareness Month. As a woman with PCOS herself, who struggled for many years with its symptoms, Dr. Fiona is passionate about health education and advocacy for women with PCOS, and serves on the Medical Advisory Committee of the PCOS Awareness Association as an expert on IVF.ca. She is also a medical advisor to Open Source Health, a women's health technology platform. The Open Source Health Precision Medicine PCOS project was started in December 2015 and may be the largest ever project to use state-of-the-art genetic and molecular research, science, evidence-based integrative medicine, and technology to help the growing underserved community of women with PCOS. Dr. Fiona also frequently lectures to professionals and is a proponent of evidence-based natural medicine and peer reviews for Natural Standard, a database on evidence-based natural medicine. She's a graduate of the Canadian College of Naturopathic Medicine in 2001 and the University, and I'm sorry, I don't know how to pronounce it, Guelph? And it's spelled Guelph, and in biological science, molecular biology, and genetics. So quite a resume, very impressive. So I wanted to welcome you to the show today. So first, I would like to ask you to define PCOS. What are some of the key criteria used in a medical evaluation?
Sure. So the most common signs and symptoms of PCOS are definitely the number one most common is anovulation, which means a woman either does not ovulate or ovulates much later than usual. And that results in cycles that are usually around 35 days or even longer than that. Meaning that the ovulation occurs usually about 1 week later than the typical day 14. So that's probably the most common symptom that women experience, and it's definitely one of the signs. One of the other common signs is androgen excess. So this is the excess of hormones in a category that includes testosterone and DHEA that are responsible for causing male secondary sexual characteristics like facial hair growth. Mm-hmm. And these hormones can also cause acne, especially along the jawline, and hair loss from the scalp behind the front hairline. So the facial hair growth, though, if a woman has that and it's coarse, especially if it's on the chin or the sideburn area, that's quite a strong marker, and she should really be looked at to see if she has PCOS. The other symptom, it's not really a criteria for diagnosis, but this is a very, very common symptom, and the reason is that PCOS is a disorder that is metabolic as well as hormonal. So there's insulin resistance, and because of that, it's easier to gain weight and harder to lose weight. So women with PCOS tend to gain weight more easily, and as a result, around 75% of them have a higher body mass index, and they tend to gain weight around their stomach area. And it's very, very hard to lose weight as well. So that's one of the symptoms that we often see.
Mm-hmm. But is that the same thing as the criteria that's used if you were to go to a doctor, for example?
No, it's not one of the criteria at all, actually. So the 3 criteria are the anovulation, which is the first one I mentioned, and that anovulation has to be long-standing. It can't just be 1 or 2 times. The androgen excess, so that can be either the clinical signs, like I mentioned, or it can be in the blood work, so there may be high testosterone in the blood. That's not as common in that testosterone testing is not as accurate at lower levels, which you'll see in women. So unless your clinician has a lot of experience looking at androgens, you might have androgen excess, but your testosterone might be quite normal. The third criteria is the polycystic ovaries on ultrasound. This is a very controversial criteria because a lot of women don't have it. The whole syndrome is named for it, yet many women don't have it. And it really reflects not cysts, but eggs that have stalled during the ovulatory process. So there's other ways to sort of look for this, but one of the newer thoughts is that we would use a test called anti-Müllerian hormone, which is a hormonal test that reflects this large number of follicles that are installed in the ovary. And it's also been found that women with PCOS secrete a lot of this hormone from each follicle. So the criteria are sort of evolving, but those are the criteria now. You need to have 2 of the 3. You don't need to have all 3.
Mm-hmm. So I understand that you had PCOS yourself. Was that the catalyst to your PCOS specialization?
Yes. So I still do have it because it is a lifelong disorder. So it's almost like a genetic disorder or genetic variant, actually, where, people are metabolic conservers, and you can influence how it affects your life. So in my case, I've reversed the symptoms of it, but I know I still have it. So I have to live my life differently than other people. But yeah, my own experience really led me to focus on this. I also am very, very interested in hormones, metabolism, and I also saw the need for it because there's just so little information on PCOS. It's been a misunderstood condition for a really long time, and there are so many women that are suffering with it.
Yeah, I'm glad you brought up the misunderstanding, but also isn't it misdiagnosed?
Absolutely, yeah. It's misdiagnosed. 50% of the women who have it don't even know they have it. And if you're thinking about 7 million women in the U.S. alone, that's a lot of women who don't know that they have this walking around.
Mm-hmm. And it's even more prevalent worldwide. I read that it affects 116 estimated women, especially among reproductive age. So maybe you can address, is it strictly or solely a condition of reproductive age?
Oh, that's such a good question. So it's actually not at all a condition of reproductive age. It's just noticeable in that population because it affects the menses and the periods, so you can actually detect it. But it's actually a lifelong condition. It starts in childhood, and it starts off with, you may not notice it, but the insulin resistance starts in childhood. But there's also fat cell dysfunction that starts in childhood. So children who develop PCOS later secrete higher levels of hormones, lower levels of hormones from their fat cells that are beneficial, like adiponectin. So they have low adiponectin from childhood. They end up having a predisposition to insulin resistance. As they go through puberty, we all become insulin resistant when we go through puberty as a matter of gaining weight to reproduce. But this goes to the extreme in PCOS, and this is when the weight gain starts. So, and then after menopause, it continues on. So women with PCOS continue to be more insulin resistant through the rest of their life. They also continue to secrete higher levels of androgens throughout their whole life compared to women without the condition.
That was really interesting, and I know you talk a lot about individual variation, and can you just give us a quick story like about Elizabeth and Sophia that illustrates that variation?
Sure. So in one of the early chapters of my book where I am defining, PCOS and just talking about variation, I give the story of 2 women. One is Sophia and the other is Elizabeth. So Sophia is a very lean woman. She's very tall. She has a lot of acne, and she's 34 years old. And And, she's always had irregular periods, and she's had hair on her face. But she's extremely slim. So her friend Elizabeth is quite curvy and has gains weight around her stomach, but has, very clear skin. And they just have different presentations. And there's a lot of women who have just different manifestations, and there's just so many genes that have been linked to PCOS characteristics within certain clear categories. So you might see it presenting very differently in different people.
Yeah, and I think as we were talking earlier, that it's important to recognize that not all people with PCOS, just like not all people with diabetes, are overweight.
Right, exactly.
Mm-hmm. So in your book, you have 8 steps to reverse your PCOS. Now, let's start with inflammation. Why is inflammation a central factor, and are there specific tests that you recommend?
Sure. Yeah, absolutely. So there are, definitely tests, but inflammation is a very central factor in PCOS. And it's really metabolic inflammation. So it would be very similar to the type that you would see in diabetes. So it's a very centralized inflammation. In PCOS, it comes from the dysfunctional fat cells, where the fat cells tend to enlarge and they spill free fatty acids out. And this is where the insulin resistance comes from, because this free fatty acids, the free fatty acids being dumped into the bloodstream causes what we call peripheral insulin resistance, and the tissues surrounding become insulin resistant. And this perpetuates the whole condition and creates an overall status of insulin resistance in the body. So some of the tests that you'll tend to see that are high in women with PCOS, and of course these are going to be higher in women who are heavier than they are in lean women. But if you compare a lean woman with PCOS to a lean woman without, the lean woman with PCOS will have higher levels of these inflammatory markers for sure. So there are markers including HSCRP, which is one of the, definitely the most commonly used markers. There are also markers, cytokines that are increased, which can be measured, like TNF-alpha and IL-6. So these are often high in PCOS as well. And then women with PCOS, in addition to this, are also more prone to autoimmune disease, especially Hashimoto's thyroiditis. So in these kinds of cases, you might see some of the autoimmune markers like anti-thyroid peroxidase or anti-thyroglobulin. In some women, you might see ESR if they have an overall inflammatory state, especially autoimmune. So, you'll definitely see some of these inflammatory markers that are increased.
And I also want to just emphasize that you have to ask for these. These are not your standard tests.
No. The CRP, sometimes they'll do that. It's a very, very inexpensive test, so most doctors will do it, and so it's worth asking. The other ones, the cytokines, are really specialized, so you might have to go to a functional medicine doctor to get those.
Mm-hmm. Now, we're talking about insulin resistance as well, which is a common feature of PCOS. And can you just explain a little bit more about the relationship between PCOS and insulin and the role that the ovaries, that insulin plays in the ovaries, and how that relates to other hormones like testosterone? Sure.
So insulin resistance is definitely central. It's an aggravating force for PCOS. So if a woman with PCOS, if you expose her ovaries to insulin, they will make testosterone. This does not happen in women without PCOS. So you can expose another woman's ovaries to insulin and they won't make too much testosterone. So this is where the two of these create this perfect storm, that predisposition to overproducing androgens combined with the insulin, the hyperinsulinemia. So the other thing is that women with PCOS secrete large amounts of insulin when they eat compared to another woman of the same weight, body mass index. So there's that hyperinsulinemia. And then the last thing I want to mention is that the very lean women with PCOS, you may see that when you check their fasting insulin levels or you check them with an insulin glucose tolerance test, theirs are normal. But they have something called reactive hypoglycemia, where their blood sugar goes up and then it drops down after they eat. And they have actually more what we call insulin hypersensitivity. And this is where a lot of it begins, in that their systems are extremely sensitive to insulin, and they tend to have more of this up and down in blood sugar. It sets them up to eat more and become more and more insulin resistant.
Mm-hmm. The other thing I thought was really fascinating is the relationship between insulin resistance and then leptin resistance.
Absolutely. So yeah, insulin resistance and leptin resistance are definitely directly related. So when you're insulin resistant, and this goes again back to that fat cell dysfunction, because leptin normally is secreted by the fat cells to tell our brains that we're full and we've had enough to eat. And our fat cells just secrete way too much leptin all the time. When we're insulin resistant, the brain then just kind of puts on the brakes. It's like, I've had enough leptin, I'm not going to listen to this message anymore. And we lose our ability to tell when we're hungry and full.
Exactly. And so that creates it's sort of a vicious cycle, doesn't it, with food and then gaining weight?
Absolutely, yeah. They find that for even lean women with PCOS, they've measured their food intake compared to other lean women of the same weight, and the lean women with PCOS eat less food, and that's how they maintain their weight.
Wow. So I know that diet and exercise are the best remedies, and I liked what you said for both treating insulin resistance and PCOS. And just to quote you, you say, "I cannot emphasize enough how your life will be transformed simply by changing the foods that you eat and by exercising. No supplement or medication listed here will ever come close to bring you the same health benefits." So.
Yeah,
totally agree with that.
Yeah, it's, here. That's basically all of it. Yeah.
So let's move on to Chapter 3, Balancing Adrenals and Improving Mood and the Role of Cortisol. I think a lot of people in Canada, where Dr. McCulloch is in Toronto, and I'm in the Washington, D.C. area, have a lot of high-powered people here, tend to really push themselves really hard. So can you talk about the relationship between PCOS and why women with PCOS make more cortisol than women without PCOS?
Yeah, absolutely. So there's interesting relationships between the adrenals and PCOS. So there's a large portion of women who have PCOS who have what we call adrenal androgen excess, and this is a specific variant of the condition. It's almost a separate kind of thing compared to the rest of it, because it doesn't relate to insulin resistance at all. It simply is such that your adrenal glands will make more DHEA when they're stimulated by the hormones that come from the brain, like ACTH, compared to somebody else. So whenever there's a stressor, there's going to be more androgen production in these women, as well as cortisol. So that's one aspect. So stress in particular is a problem for these women, and it's about 30% of women with PCOS. The other aspect is there, definitely that weight gain and insulin resistance are related to cortisol and vice versa. So they're a vicious cycle. So the more stress you have, the more cortisol, the more belly fat you gain. And this makes you more insulin resistant. So then you have that vicious cycle. And then the last part of it is that women with PCOS are more prone to mood disorders, so depression, anxiety, even OCD and bipolar disorder. So all of these are more common in PCOS. So, yeah, and the reason for that is that there's a few reasons. One is that it's a stressful condition. So you're dealing with facial hair, irregular periods, infertility, hair loss. It's very stressful. It's very isolating. But beyond that, what they've done is they've been able to do studies outside of those factors, and they've determined that there's actually a predisposition just most likely related to the inflammation and the hormonal disruption, and it changes the female's brain chemistry quite a bit.
Wow, that's really fascinating. So you also distinguish between adrenal fatigue and adrenal hyperactivity. What is the difference?
So adrenal fatigue, and I always think of the adrenals really as they just respond to the messages they're given by the brain. They're not necessarily, it's not the same as hypothyroidism when your adrenals are not, have had a lot of stress, unless you have a condition, like Addison's or Cushing's, which is less common. But most of the time, it's the brain that's causing these issues, and it's just a continuous input of stress. And eventually what happens is, in adrenal fatigue, is that the entire entire axis sort of shuts down, and we end up with low levels of cortisol, but also low levels of other hormones too. So it's not just specific to the adrenals. And so that's really what adrenal fatigue is. It's sort of a term that may not be exactly what's going on there, but it is entirely related to the brain. The adrenal hyperactivity is really a stage where you're in stimulation of that axis and you're making higher amounts of cortisol. And then there's everything in between there where you're having dysregulation. So normally your cortisol should be high in the morning. It rises very early in the morning, wakes you up according to your circadian rhythm, and then it declines from that point on, and it becomes lower in the afternoon, and it's very low at night, and it allows you to sleep through the night. So whenever there's a dysregulation of that pattern of cortisol, then that's something that is more like a cortisol dysregulation. But these are all really related to the input of stress on our brain and ups and downs of blood sugar. When your blood sugar drops, your cortisol goes up. So there's all these different patterns, and it's really because of the stresses that your brain is sensing.
I know one of the lifestyle changes you recommend, and I do the same thing with my clients, like meditation, yoga, and sleep. I think you touched on that very briefly, but that's a very important component of trying to regulate your hormones.
Oh, yeah, it's so important. Sleep is really important.
Yes. So moving on to excess androgens, we talked briefly about that in the intro, but I was wondering if you could maybe separate out facial hair growth from hair loss, alopecia. Are those separate, or are they part of the same sort of spectrum here?
They are somewhat related. So they're basically, and there's also genetics involved. So it depends on how much first of all, you have the conversion of testosterone into dihydrotestosterone within the skin in that area. So women who have more of that enzyme in their skin will tend to make more facial hair, and they'll tend to also lose more hair from their head. So those two tend to be similar in that way. But there's also a lot of genetics, like certain ethnic backgrounds, like, for example, Asians will tend to not have the hair growth as much, just because genetically there's less of that enzyme and predisposition. So there's a lot of different factors there, but they are somewhat related. And there's so many other things that relate to hair loss, like iron deficiency, and thyroid. So often if a woman has a combination of a couple of factors, like PCOS and then iron deficiency and then hypothyroidism, then she might be much more likely to lose hair.
Mm-hmm. So acne is also common among women in general. So how do you differentiate the acne that is just, kind of a common thing among teenagers, for example, versus the kind of acne you see in PCOS?
Oh, that's a good question. So as a teenager, I would be very hesitant to use acne as a sign of androgen excess. All teenagers have androgen excess, actually, so it's very common in that age group, to have acne. But it's less common to have acne as an adult. Specifically, if it's cystic acne on the jawline area, the chin, there's a lot of androgen receptors there, so that, the same place where we grow facial hair, so that area, and then particularly if it's as an adult, if it doesn't respond to treatment, if it comes back after treatment, and if it's also hormonally mediated, so it would be higher around the ovulation time and then much higher prior to getting the period. But alone, it's not quite enough because there are other things that can cause acne, but you would have to use it in combination with some of the other symptoms.
Mm-hmm. So you talk about conventional treatments for excess androgens, and it's common for doctors to prescribe birth control pills. I know a client of mine who came to me with PCOS have been prescribed that. So can you talk about the pros and cons and where you come out on that?
Yeah, so the birth control pill is not my favorite treatment, and there's a few reasons for that. One is it's just completely masking the menstrual cycle effects. So yes, you'll get a period every month, but it's just induced by the artificial hormones that are in the birth control pill. But the thing I really don't like about it, these are the two things I really don't like. Number one is it increases insulin resistance, which is the absolute worst thing. So although you're masking the effects on the period, most women gain weight on the birth control pill, like maybe 10 pounds, and that's not helpful at all when it comes to PCOS. So that aspect to me is the number one negative. The second one that I don't like about it is it increases the risk for blood clots. And in particular, the pills that they prescribe for women with PCOS are the ones that are anti-androgen. So they do have the progestin in them is almost similar to spironolactone, which is an anti-androgen drug. That is more likely to cause blood clots, and that's a risk women with PCOS are already at risk for. So I don't like that. It's a rarer kind of occurrence than the insulin resistance, but I'm still not a fan. And then the third thing I don't like is that it causes a lot of women to go undiagnosed until they're ready to have children. So they have these irregular periods. They go in, and the doctor's like, okay, just go on the pill. But they're never given an answer as to what's going on with their body, so they're just put onto the pill. They stay on the pill. Then they come off of it and want to have children, and then they realize over time that they've had PCOS all this time.
Mhm. Yeah, so the underlying issue really isn't addressed.
Exactly. Yep.
Mhm. So you also talk about phytoestrogenic plants, and there's some that you would recommend, but you don't recommend soy. Why is that?
Soy. So I don't like that soy is genetically modified, first of all. For the most part, yeah, that's the number one thing I really don't like about it. The other is that it's a goitrogen, so it can lower thyroid function. So I'm not a fan of it for that reason. Those are the two big ones.
Okay, and there's a list of all these in your book. Also, you talked about HBO Access, which this gets to the order of your book, that it depends on many factors. So you talk about, before you get to Chapter 5, insulin resistance, stress, androgen excess, and inflammation. So you want people to address that first, correct?
That's right. Yeah, a lot of the time when you address those, because they're more at the whole crux of the issue, then a lot of the other problems actually just dissipate.
Mm-hmm. So, we touched on fertility or infertility being a real concern among women with PCOS, which is understandable. My client was in her mid-20s, and, I think many young adult women want to have a family. So when do you, and how do you start addressing that?
Yeah, so I always look at PCOS. It's the number one cause of ovulatory infertility. So it's very, very common. If you go to a fertility clinic, and when I practice, I have a lot of patients coming in for fertility, but and you just see a lot of women with PCOS. But it's really a condition of subfertility, not so much infertility. So most women who have this will conceive and have children. So that's important to keep in mind. The fertility relates to not ovulating, first of all, and secondly, the effects of insulin resistance on the endometrium and on the quality of the follicles in the eggs. So this can be improved actually quite a bit. So when we're looking at treating infertility, we're going back again to that nutrition and lifestyle, and we're seeing, that the fertility will definitely improve. The other thing to keep in mind is that as women get older, their egg count becomes less, and in women with PCOS, having a lot of eggs actually aggravates the condition because the ovary is making more and more testosterone. So they tend to become more fertile when they're a little bit older. Maybe around 35 is really, many women with PCOS are quite fertile at 35. And studies have shown that they retain the same fertility rate from the time they're 25 to 41, unlike other women. So, and in fact, I find a lot of women in their 20s with PCOS are far less fertile than they are when they get older.
Oh, that's really interesting, too. You may not know the answer to this, but does that mean they're having delayed pregnancies or getting pregnant later in life?
They are, yeah, absolutely. I have a lot of the women in my practice who get pregnant in their 40s have PCOS. Mm-hmm.
So you also in Chapter 7 talk about creating a healthy environment, and I won't go into that so much, but I encourage listeners, to read that. You talk about avoiding BPA, which is it's a toxin that can be found in plastics and so on, and can interfere with thyroid function. So moving on to Chapter 8, I wanted to spend a little time on eating a balanced diet, and I know we're on the same page with organic whole foods. I wanted to talk about the insulin counting system, and can you explain sort of how that's structured? I know that it was based on some of the same research that by the authors of the glycemic index and did a previous show on that. But I wanted just to ask, if you can talk about the FII and FID and your system, and if you found it useful with your PCOS clients.
Oh, yeah, absolutely. So this is, for me, the most exciting thing that we know currently about how to treat PCOS with diet, because PCOS is really a condition of insulin resistance rather than glycemic disruption. So although, they are related, but the insulin index is basically similar to the glycemic index, but it measures the amount of insulin secreted after eating about 239 calories of a given food. So it's a measure of insulin secretion. So, of course, it's extremely valuable when it comes to looking at women with PCOS and foods. The FID sits on the shoulders of the FII. So the FID is the food insulin demand. So as you can imagine, 239 calories of broccoli is really, really different than 239 calories of rice. So the FID tells us about quantity. So it's a calculation which takes the free insulin index and turns that information into a quantity, and it comes up with a count per quantity of food. So what I've done for that is create a nutritional plan that it balances blood sugar and keeps the blood sugar stable after the meal for the women who are insulin hypersensitive and have reactive hypoglycemia, but it also reduces and controls the insulin demand, so there's less insulin secreted. And it's really based around adding up the points of the different categories of food: protein, vegetables, healthy fats, and then the last category is carbohydrates. So those four are the structure, and then there's a certain count for each category, and it's added up to a total recommended count per meal. And that can be adjusted depending on the woman.
Right, and I want to also emphasize that, you're basing this on a whole foods diet, probably similar to, to the paleo diet. So
it's very, very similar to the paleo diet.
Because a lot of the research was done, as you know, on more processed foods. So we're not talking about that here.
Yeah, absolutely. Like if you look at the foods they tested, there's lots of chips and fries and chocolate bars and things like that. So this is like an adaptation of that kind of. I'm using the idea and the metrics, and I'm applying that to a whole foods diet, which is actually very, very similar to paleo. There are a few differences in that we don't completely, if there's rice is allowed, but the quantity is very small, but otherwise it's extremely similar to paleo in most other ways.
Mm-hmm. Compared to the glycemic index, there was a smaller amount of studies done on this. It's like 16 compared to over 200. And then insulin is also an anabolic hormone, which helps some amino acids in our cells. So in my opinion, I think more research needs to be done. I was wondering what you thought of that.
Yeah, so I think absolutely. We don't want to just lower insulin, but we want to modulate it. So with PCOS, what we want to do is to create insulin sensitivity again, but also to stabilize the blood sugar. More research definitely needs to be done. They are doing quite a bit more research on it right now. But I think it's really like how do you take that information and how do you use it? So, and for what person are you using it for? So just having, shutting insulin right down to zero is not going to work for most women. And especially if you're working out, you do want to have high insulin after your workout to allow the amino acids to enter the muscle cells. So it is an important hormone. When it's high and our cells don't respond to it, that's where we have a problem. And because in PCOS, those high levels, the ovary actually does not become insulin resistant, which is really interesting. It retains insulin sensitivity when there's peripheral insulin resistance. So this is where we have a problem. So it's a little bit of a different condition compared to someone who's just wanting to lose weight or something else. So we really want the peripheral tissues to become more insulin sensitive so that the ovary is not continuously exposed to high levels of insulin. And this is why really, like a woman with PCOS can eat the same diet as somebody else and responds totally differently.
Mm-hmm. And that is very fascinating, harking back to that whole individual variation that we were talking about earlier. So it sounds like you're customizing it and you're seeing some good results.
Mm-hmm. Oh yeah, we've been seeing amazing results. We've had lots of women just, I can give you an example of one woman. She's a professional athlete at college, and she exercises all day, every day. Like, this is her focus. So basically, she's tried all sorts of different kinds of diets throughout the years, and she's extremely active and has never been able to lose weight around her midsection. And so she did this program, and within around 1 month, she had already lost 4 inches around her midsection and 5 pounds, and it all came right off her stomach. And that's basically all she did. But she has PCOS, so really it's just about keeping the blood sugar stable and managing the insulin sensitivity while giving plenty of protein and increasing satiety. So that's the whole structure of it. So it tends to work well for women with this condition, because that underlying insulin resistance is there. There is that tendency to that roller coaster blood sugar. So this program seems to work really well for many, many women.
That's great. So I want to thank you so much for being on the podcast today.
Thank you for having me. It's been wonderful.
Great. I've really enjoyed it. You can learn more about Dr. McCulloch's book, 8 Steps to Reverse PCOS, and her White Lotus Clinic, where she has her practice, at www.drfionand, and is that always in caps, Fiona?
No, it doesn't have to be in caps.
Okay.
Yep.
So drfionand.com. The next episode, I will be chatting with the authors of one of my favorite paleo cookbooks, Mediterranean Paleo Cooking. Foodies, stay tuned. Thanks for listening, everyone, and have a great, healthy week.